Have the honor and privilege of introducing our Grand Round speaker today, Antoine Wrice, or Dr. Antoine Wrice. So just a little bit about Antoine. He started his educational journey at Miami University in Ohio, earning a Bachelor of Science in Microbiology, and then went on to obtain a Master of Science in Anatomy at Wright State University in Ohio. From there, he attended the esteemed Howard University College of Medicine in Washington, D.C., and decided to pursue a career in pathology. He matched into our department at the pathology department here at the University of Minnesota and quickly decided that he wanted to do straight track in anatomic pathology with a future career focus on forensic pathology. I am very glad to have gotten to know Antoine here, from the resident get-togethers to the events of like just playing volleyball at the beach in the summer months. And well, here at the University of Minnesota, Antoine has provided to us a calm, cool, and collected atmosphere to our residency program. His kind of go with the flow attitude always made me feel like everything was going to be okay. He'll be a great addition to any place he chooses to go next. And this July, Antoine is going to be headed over to Cleveland Clinic for his forensic pathology fellowship after passing the boards, of course. And so with that, I'll pass it over to Antoine, and I'm really excited to hear about his topic.
Well, thank you much, Cade. I couldn't have said it better myself. So I'll share my screen quickly. Let's see if I can get this right. How do I get this off? Okay, so hopefully everyone can hear me well. I'll just reiterate again. My name is Antoine Wrice. I'm a third-year Path resident, and today I will be talking to you guys a little bit about bias in medicine, entitled Implicitly, Explicit. I have to click. There we go. Okay, just a few objectives for today's talk. I want to kind of define and describe implicit bias and its related mental associations. I want to detail some current events and research that exemplify healthcare-associated bias and discuss their impact on both an individual and systemic level, and to discuss various avenues for self-improvement, self-improved reflection, advocacy, and bias literacy within the healthcare system. I have no disclosures for the talk today, so we'll get right into it. Implicit bias. I think implicit bias is one of those concepts that we as people have a general understanding of. We hear it thrown out in society frequently, so we have a general context to place implicit bias. However, I always think it's good to start with good definitions to be as accurate and precise as possible. And one of the institutes that helps us accomplish that is this Kirwan Institute out of The Ohio State University. And this institute essentially studies race and ethnicity, and every few years they put out this wonderful review on bias, implicit, explicit, and covers many different facets of society, healthcare, justice, you name it, they cover it. So what they actually define implicit bias as is the attitudes or stereotypes that affect our understanding, actions, and decisions, and it's in an unconscious manner. These biases encompass both favorable and unfavorable assessments. They're activated involuntarily, and because they reside deep in our subconscious, they're not easily accessible through introspection. These biases are different from any biases you may choose to conceal, at the dinner table for social or political correctness. And just a few other observations that the Kirwan Institute makes about implicit bias is that they're pervasive in nature. Don't let anyone tell you that implicit biases don't exist, or that they don't have implicit bias, because everybody has implicit biases. Even judges that are supposed to be impartial can display implicit bias. These associations don't necessarily reflect your outwardly expressed or endorsed positions, so they can be different from that. And they tend to favor your own in-group. However, you can still hold biases against your own in-group as well. And because these implicit biases are malleable, they can be unlearned, although difficult. And there's a number of techniques that are beyond the scope of this talk that you can do. So I just want to start off with a little exercise. You can see we have a series of colors and words here. I want you guys to say aloud the color of each word that you see here. And this is just going to get to how dynamic our automatic processing is. So blue, yellow, red, purple, black, easy enough, right? Now, again, I want you to say aloud the color of each word.
Yellow, red, purple, black.
See, so yellow, red, blue, green, purple. So if you hesitated just in the manner I did, or if it took you a little more time, that's what was intended. Because what I explicitly told you to do kind of differed from what your implicit, kind of what you're implicitly taught, in that these colors and words matched up so you can go through it relatively easy. However, when I flipped the context a little bit, we tend to struggle. So that's the plane in which that implicit biases work on, that automatic processing. You don't have to think about it, you just do. When you have to think about it, that gets into a little different area. So you can't discuss implicit bias without first talking about a lot of these other mental associations that are kind of intimately intertwined and intimately associated with implicit bias. So we'll kind of go over some of those quickly. So schemas, what are schemas? Schemas are these templates of knowledge that help us organize specific examples in a broader category. So we have these mental shortcuts that we create that we can quickly throw things into and assign to different categories. So a good example of that is, as soon as we meet somebody for the first time, we can classify or characterize these individuals based on age, based on race, based on gender. And it so happens that if you have any meanings that you already associate with age, or you associate with race or gender, those associations are going to be placed on that individual, whether you consciously realize that or not. So stereotypes, we're all frequently accustomed to stereotypes. These are beliefs that are mentally associated with a given category. These common associations, they can be positive, they can be negative, and they're automatically assessed. However, stereotypes may or may not be accurate. Some traditional stereotypes that we hear in our society a lot: Asians are good at math, elderly persons are frail, so on and so forth. Attitudes, everybody kind of knows what that is. Evaluative feelings, such as having a positive or negative feeling towards something or someone. In-groups and out-groups, kind of self-explanatory. In-groups are essentially one of us. We tend to show favoritism, we kind of extrapolate our characteristics, our feelings, and kind of put them on to other individuals. And that helps confer a high sense of regard and trust between people. However, that these in-groups are not only self-selected. Bias has been shown in randomized groups and fictitious groups in given experiments, to where you, even just when placed randomly together, you tend to extrapolate those characteristics onto essentially random individuals, and you find that common ground. Out-group, of course, those are individuals different from ourselves. So immediately with that dichotomy, we're able to formulate an us versus them distinction within seconds. And if you recognize this little GIF from a very great movie from back in the day, more kudos. So internalized oppression. So now we're kind of getting into some of the effects that are associated with the implicit bias. These are internalized negative messages by a target group about a target group. Individuals can feel shame or self-hatred or have low self-esteem. And it can manifest as an individual expressing lower expectations for themselves. They see limited possibilities for themselves. They may not want to associate with their own group. They may try to assimilate or pass in another group. They may identify with the dominant group in kind of like a Stockholm syndrome. And they may actually adopt the myths and stereotypes that have been placed on them and outwardly project those. And the most important thing here is that these internalized messages tend to cycle through generations. So we're not talking 1 and 2 and 3 years, we're talking decades and centuries. is really pervasive. So microaggressions. So now we're getting into kind of the more overt side of the mental bias or implicit bias associations. So these, according to Daryl Wing Su, who's kind of at the forefront of some of this research out of Columbia, these are everyday verbal, nonverbal, and environmental slights, snubs, or insults, whether intentional or unintentional, which communicate hostile, derogatory, or negative messages to target persons based solely upon their marginalized group membership. And this term essentially didn't exist until the 1970s, when it was coined by Dr. Chester Pierce, a psychiatrist. The micro and microaggressions doesn't actually refer to its scale of impact. It's pretty impactful. It just refers to how frequent, how routine microaggressions can be in society. There's been a bunch of research on microaggressions, and it's noted to have a pretty profound impact on marginalized groups, manifesting in impacting standard of living, education, employment opportunities, as well as healthcare inequities. And like most things, the most detrimental forms of microaggressions are actually delivered by the people that are the most well-intentioned, but they're just simply unaware. So they're not really understanding why, or that they're being microaggressed towards someone. So just a little background, historic perspective on implicit bias. So in this study by Samuel Gardner and John McLaughlin, back in 1983, Racial Stereotypes, Associations, and Ascriptions of Positive and Negative Characteristics, this was kind of the foundation for implicit bias research. And what they did in this study is they took this lexical decision task, as you can see a little representative here, and they looked at reaction times and error rates of individuals as they did like a word association. So they paired words and non-words with the word black or white. So they wanted to look at how fast you reacted to the grouping of words being a word or a non-word, essentially, as they were paired. And what they found was that there was a reliably faster pairing of positive attitudes with whites as opposed to blacks. And this was regarded as the first piece to kind of demonstrate this implicit stereotyping. So Patricia Devine followed that up in 1989 with her paper Stereotypes and Prejudice, their automatic and controlled components. And she argued that these stereotypes and personal beliefs are conceptually distinct cognitive structures. So she hypothesized about this dissociation model that differentiated your implicit or automatic processes from your explicit or controlled processes. So she set up a series of studies to look at any kind of implications of prejudice that would occur in this kind of model. And what she found through these series of experiments were that both high prejudice individuals and low prejudice individuals, as determined by racism mosaic scale that they were told to complete, that both of those individuals were able to produce a list of cultural stereotypes, and that when presented with a vignette with a Black character displaying some kind of ambiguous behavior, they interpreted that behavior as hostile. However, where they differed is that when asked to write about their thoughts on Black Americans, the quote, low prejudiced individuals actually express more equality themed thoughts. For example, it's unfair to judge people by their skin color, as opposed to the high prejudiced individuals that expressed more stereotype congruent thoughts. So this kind of just supported this dissociation model, in that a person can be low prejudiced and hold this kind of stereotype in their mind. And with that, it causes unintended influence on future judgment. This has since, there's competing theories on whether it's actually a dissociation model present or something else. So they kind of go back and forth in the current research. So implicit bias not only affects race or gender or sexuality, it can get into socioeconomic status, your age, body habitus, behavior, pretty much anything you think about, it can be affected by implicit bias. So let's get into the medicine side finally with enough background information. So how do these types of bias manifest in medicine? So first, let's touch on sexual orientation bias. So this is an article published in the Journal of Surgical Education in 2014 entitled Attitude and Perceptions of Other Underrepresented Minority in Surgery. And what they mean by the other underrepresented minority is they're referring to social or sexual orientation. So what they essentially did in this study was they sent out online surveys to all of these general surgery programs that were ACGME accredited. They received results back from 388 residents. 43 considered themselves LGBT persons. And what they found immediately, as you would expect, there is no statistical difference in happiness in their program, the fit of their program, and co-resident rapport. So seemingly both sets of individuals are doing well. However, they did note that it was greater than 30% of LGBT residents, they didn't reveal their sexual orientation when applying for a general surgery residency. This is high, these are high stakes, so people did not feel comfortable. But where we start to see a big discrepancy between the LGBT residents and the heterosexual residents is when they were asked to fill out or essentially agree with the following statements or disagree or remain neutral. And first you can see there was 42% of the LGBT residents versus 2.7% of the heterosexual residents that disagreed with the statement of feeling comfortable bringing their spouse or their partner to formal surgical department events. That continues with the next statement. 36% of the LGBT residents disagreed versus 3% of the heterosexual disagreed that they felt comfortable openly discussing their spouse or partner with fellow surgical residents. And again, 59% of the LGBT residents disagreed that they felt comfortable openly discussing their spouse or partner with surgical attending physicians. So obviously this is a big problem here. It speaks to the kind of culture that medicine assumes and people not feeling comfortable, not feeling accepted enough to be their true selves. Additional results that they found were that 57% concealed their sexual orientation from their fellow residents as well. 52% concealed their sexual orientation from surgical attendings, and they feared for negative evaluations being derived from that. And really eye-opening is that 54% of all of the residents have actually expressed that they witnessed homophobic remarks by nurses or residents, and about 30% or 114 of the total residents witnessed homophobic remarks by surgical attending physicians. So kind of in response to that, Kisa Fallon-Bennett had this great commentary piece published in Academic Medicine, AMC, entitled Implicit Bias Against Sexual Minorities in Medicine, Cycles of Professional Influence and the Role of the Hidden Curriculum. And what she means by the hidden curriculum is essentially your culture and your atmosphere, the things you pick up from that culture and that atmosphere, things that you aren't explicitly taught, but things you kind of pick up by observation. And what she did in this commentary piece was kind of give context to our previous article and kind of focused on the fact that you have a lot of studies that support correlations with individuals that conceal their sexual orientation and poor health outcomes, whether it be stress related. We see in current literature and current society how prevalent the suicide rates are amongst LGBT individuals. So it kind of speaks to that. But it not only affects the particular individual that's concealing, there's a kind of downstream ripple effect in that the more concealment that occurs, the less chances that their colleagues get for these intimate personal interactions that can help challenge their biases. And to that point, this article by Burke et al. In 2015, Do Contact and Empathy Mitigate Bias Against Gay and Lesbian People Among Heterosexual Medical Students? And this was a report from Medical Student Changes. About 4,400 first-year medical students were surveyed via a variety of modalities of feeling thermometer assessments, implicit association tests, self-report items, interpersonal reactivity indexes. And this kind of looks at empathy and implicit bias and how much contact you've had with individuals and explicit bias. And what they actually found was that 45% of those individuals expressed some explicit bias, and 81% expressed at least some implicit bias against gay and lesbian individuals. However, kind of a mitigating factor was the amount and favorability of the contact. It actually predicted a positive implicit or explicit attitude in individuals, and any kind of cognitive or emotional empathy displayed predicted a positive explicit attitude, but had no effect on implicit attitudes. So we can see that kind of mitigating factor there. So getting back to our figure here, as we are less prone to challenge these biases, the biases become reinforced, and we create these heterocentric policies, and they become institutionalized, and there's little driving force to change them, and they become stronger and stronger, essentially. And with that, you further discourage any kind of disclosure of sexual identity from individuals, and you just repeat this cycle of self-perpetuating bias, and it assumingly gets stronger and stronger with each turn and harder to disrupt. So we can see the problems there. So let's transition a little to gender bias. So a lot of individuals may be familiar with this study that came out in July, August of 2020, entitled Prevalence of Unprofessional Social Media Content Among Young Vascular Surgeons. And what the authors did in this study is that they looked at 480 young vascular surgeons. They found that 235 of them had public social media that they could browse through, essentially. And what they were looking for is potentially unprofessional content versus any clearly unprofessional content. And you can see what they classified as potentially unprofessional and clearly unprofessional. And they found that out of all of those individuals, about 25% expressed some kind of potentially unprofessional content, and 3.4% expressed some clearly unprofessional content. So again, the who of this study, these graduating vascular surgery trainees, they looked through all this social media looking for unprofessional behavior. And what they noted that they did this, why they did this, was because social media can have this profound impact on patient choice of physician, where they go to the hospital, what kind of medical facility that they utilize. In addition, social media affects the reputation of the professional, whether it's among your peers, whether it's among your current employer or future employer. They want you to be aware of social media. So this is just a table of some of the breakdown of where they found the unprofessional, clearly unprofessional versus potentially unprofessional. And what I have highlighted here is kind of the bulk of the potentially unprofessional behavior, where you can see 29 individuals were seen holding alcohol versus about 9 individuals were seen with inappropriate attire. So you say, oh, okay, that's just the results. However, what they indicated as inappropriate attire included pictures in underwear, provocative Halloween costumes, provocative posing in bikinis or swimwear. And from that, I want you to ask yourself, how often have you seen the association between provocative Halloween costumes and, let's say, a Bob the Builder Halloween costume or a Superman? You see those associations with the, quote, sexy nurse or the sexy police officer, the sexy anything, any costume that follows, which particularly affects women, as well as the provocative posing in bikinis. You don't see that associated with males at all. So from that point, hashtag MedBikini went viral around July of 2020. And what this movement essentially was a bunch of women physicians and healthcare providers that flocked to social media in protest of this gender bias, in protest of the overt misogynistic attitudes. They wanted to promote body positivity. So it was a fantastic movement, and you can just see a lot of the posts that were made, and the women physicians wanted to depict themselves in their normal work attire and then at the beach, holding drinks, again, work attire. And one particular tweet I thought was interesting by Darian Stratton was, "Hi, I'm a medical student and I wear bikinis. Here I am post-night shift, enjoying life like a normal human. Did I spend my night responding to traumas? Yes. Is there a White Claw in my cooler? Also yes. Women can be all the things and also professional." Hashtag Met Bikini, hashtag Met Twitter. There was an anonymous quote by a person posted in the Boston Globe that quoted that this paper is a perfect example of unconscious bias by labeling such things such as provocative Halloween costumes, bikinis, and opinions on abortion and gun control unprofessional. Who do you think they are primarily targeting? But not only women came out to voice their displeasure, men came out in support as well. You can see this tweet by Michael Novick. "Women are the trailblazers of the medical community, as they are in every other aspect of society. I and my bald head stand with my colleagues against sexism and misogyny in medicine." Greg Matthews noted how the hashtag was amazing. There was 10.8 thousand posts in less than 24 hours, still is soaring. And he loved to see the Med Twitter voices united against systemic misogyny. So with that outpouring, that social pressure, this article was actually retracted. And you can see on the right here, that's the editor's statement regarding the retraction. I won't go through it all, but I kind of just summed up 3 main points that they made. So they expressed that they did believe that the authors had good intent, that they were trying to advise these young vascular surgeons. However, they noted that during the review process, they failed to identify any errors in the design, the experimental design. So they did not see anything wrong. They didn't find any bias. And kind of a cherry on top, which is too little too late in my opinion, the third point, the authors did not receive approval from the APDVS to utilize their directory, which you would think that was something that would be determined beforehand, but it just kind of seems, oh, I'll throw this in here to have a little more objective criteria. So that was that. So let's transition now into a little racial bias, particularly the pain management disparity as it relates to race. So this was a TikTok from Dr. Jennifer Lincoln out of Oregon, is OBGYN out of Oregon, that I came across that I thought was really interesting and essentially went viral again. So it's pretty short. So I'll let Jennifer say what she has to say.
Do Black people feel pain the same way as white people? The 2016 showed that 50% of medical students and residents who were studied thought that Black people couldn't feel pain the same way because they had thicker skin or their nerves didn't work the same way. Where is this from? Holdover from the days of slavery when white people had to feel better about using slaves. People used to be operated on without anesthesia and were used studies without their consents. A convenient lie. To this day, Black people are less likely to get the same treatment in terms of pain medication. They're more likely to wait long in the emergency room. They're less likely to take it seriously. It's a holdover from the days of slavery. And this plays a huge role in the Black maternal and morbidity. This is the call to action. Doctors, nurses, anybody in the medical field, check your implicit bias. If you see spreading these lies, stop them, but still stop every time you're caring for somebody who has a different color than you and check your bias. If you have color, speak up. If this is happening to you, to speak to a different doctor, report them, speak up.
Also know it was a bad idea to take.
Okay, well, thanks for that, Cade. Sorry for the technical difficulties. So I was very curious to look at the article in which Dr. Jennifer was referencing, and it's this article that was published in PNAS in 2016, Racial Bias in Pain Assessment and Treatment Recommendations and False Beliefs About Biological Differences between blacks and whites. And essentially, given there's a lot of support, research support that confirms disparities in pain management, they kind of hypothesized in this study, there's kind of two routes of why these disparities arise. Either the physicians recognize Black patients' pain, but decide not to treat it, or the physicians don't recognize Black patients' pain in the first place and thus cannot treat it. So they examined any kind of association between these biological beliefs and racial bias in terms of the perception of pain and its associated treatment. So essentially what this study did is they had a survey that went out to a bunch of laypersons and medical students and residents, 92 versus 222. And you can see they have a bunch of items on here, and the goal was to have the individuals respond whether they possibly, probably, or definitely thought these statements were true, or possibly, probably, or definitely thought the statements were untrue. And you can see the statements with asterisks are the statements that can contain some kind of factual support in the medical field versus the highlighted or bolded statements are a little more myth-based, not fact-supported. So I'll just point out a couple of the items here. Again, speaking to that discrepancy in pain, Blacks' nerve endings are less sensitive than whites. About 20 of the individuals, the laypersons, thought that that could be true. And we can see how many residents, or med students and residents, also thought that was true. 8 first years, 14 second years, dropped to 0 in third years, but 4 residents. Or that Black skin is thicker than whites. 58% thought, or 58 individuals thought that that could be true. And you can see just how many medical students and residents thought that was true as well. Just another one, whites have a more efficient respiratory system than Blacks. 16 out of the 92 thought that was true, and 8 first years, 3 second years, 2 third years, 1 fourth year thought it was true as well. So we can just see that these things are not specific just to lay persons, or they predate, you know, the medical students' involvement in medicine kind of things. They're pervasive in society before we even get to that point. So some of the other findings that they saw in this paper is that about 11.5% of the false beliefs were endorsed by medical professionals in comparison to 22.4% of the false beliefs endorsed by lay people. And where she got that 50% of medical professionals was from here. They noted 50% actually believed at least one of the false beliefs were possibly, probably, or definitely true, as compared to 73% of the laypersons. So that's obviously an entirely significant number. It's way too high, but that's what it is. As far as the pain rating and as a function of the endorsement of false beliefs, they did a few slope analysis, and we can see these are the lay people up here. These are the medical professionals down here. And what they were able to determine, you can see that there's no difference in the average pain rating in lay people in those who have a low endorsement of false beliefs. However, we can see the racial bias demonstrated here, as you can see individuals with a high endorsement of false beliefs rate the Black individual's pain as less than the white individual's pain for a similar, you know, vignette style.
Sorry, Antoine, sorry to interrupt.
Mm-hmm.
Maybe you mentioned it, but I missed it. When they did they list data about those who were interviewed or questioned about their racial background as well, or that was not relevant to this discussion?
I don't think it was as relevant, unless I'm mixing this up, but I think that the predominant individuals in this study were white individuals. I can't remember the exact number, but both white and black individuals took part in the survey. So it's kind of all encompassing.
It would have been a bigger problem. Thank you, anyway.
Yeah. So we can see also, again, with the medical professionals, the racial bias, again, for individuals that endorsed a high sense of false beliefs, the black patients are rated as having a lower average pain as compared to the white patients. However, we can see down here that the inverse is present for individuals with a low sense of endorsement of false beliefs. So I thought maybe this is kind of like a compensatory mechanism where the black patient's pain is rated a lot higher than the white patient's pain. So very interesting. So the question, we have all of this bias in medicine. However, who's going to take the blame? We have to put the blame on somebody. That's just what society likes to do. So who's going to take the blame? So in this case, I think medicine has a lot of culpability. The physician itself has a lot of culpability. But the first point is that humans are inherently flawed. Like, we just don't process at the level needed to kind of protect ourselves from falling into these implicit bias, explicit bias traps. So that's the onus is on the humans at first. Second, they're in the psychosocial realm. There's a phrase referred to as cognitive busyness. And because in medicine we deal with this diagnostic process and such time pressures and uncertainty, we tend to get cognitively overloaded, and that has shown to cause more bias by itself. So when we get more cognitively overloaded, we get a reliance on stereotypes for efficient decision making, and leads to more bias. As far as medical training, we tend to emphasize group level information, for example, population risk factors that tend to reinforce minority stereotypes. So we get all of these vignettes and clinical scenarios where you depict a lot of minorities in unfavorable circumstances of their illness or addiction, HIV, et cetera, et cetera. And number four, the majority of physicians are going to be going to follow the scientific process. They're going to be really objective and very calculated. So if presented with questions about whether or not they express bias or whether you have bias, individuals would probably say, no, there's no way. You know, I follow a methodical, objective process, the scientific process. There's no way I can express implicit bias in something. So all of those are the reasons why we're culpable. And this kind of bias outright leads to healthcare disparities in pretty much all realms of medicine. And this was kind of demonstrated with this article, Physicians and Implicit Bias, How Doctors May Unwittingly Perpetuate Healthcare Disparities. This is by Elizabeth Chapman, and it was published in JGIM 2013. So what they essentially did, I'm not going to go through all this, it's just a picture so you can get an idea, but they compiled all of these studies and they highlighted these correlations between bias and healthcare, or bias and disparities. And you can see we have a number of different stereotypical groups and what kind of bias and what the results were. So just keeping with the racial bias in treatment, pain management aspect, there was a couple articles that they noted. Cooper et al. In 2012, this actually showed a correlation between implicit pro-white bias of individuals after they took the implicit association test and perceptions of poor communication and lower quality of care in the Black patients. Penner et al. In 2010 showed that Black patients, they were less satisfied when the physicians had a low explicit bias, but a high implicit bias. They were perceived as being less friendly, less warm, less team-oriented. So you say, Antoine, that just because you have a perception of a poor care or communication. It doesn't necessarily mean that you have inappropriate treatment, or if your treatment was inadequate or the recommendations for your treatment were inadequate, right? On the contrary, there has been a lot of studies that have linked implicit bias by the provider with contrasting treatment decisions. And that's kind of manifested in a couple articles here. Green et al. In 2007 looked at IM and EM residents, and the individuals that had greater implicit bias, when presented with a vignette, they were significantly less likely to recommend thrombolysis for Black patients than individuals with less bias. Todd et al. In 1993, the Hispanic patients were 7 times less likely to receive opioids in the ER versus non-Hispanic patients when they had both similar injuries. Todd et al. Followed that up in 2000 and duplicated the findings in Black patients. So this is another video, but I'm not going to try to play it, but I'll just kind of try to sum up. So this was another viral video that was posted to Facebook late 2020, I think November, December 2020. And this is Dr. Susan Moore, who mentions in her post that she tests positive for COVID. She's at this hospital, and she goes on to describe essentially how she's being treated, how the doctor in charge of her care essentially wasn't believing her, believing that she was in pain, was kind of dismissive of her questions and her kind of advocacy for herself, and essentially wanted to send her home. And it's kind of a long story. I wish it was able to play, but I'll kind of just go through the updates instead. So alongside the video, she posted these updates, and they're as follows. So the update 1, she's at she spoke to the CMO of this IU medical healthcare system about her treatment. This doctor is known to have a poor reputation, dating as far as back as 3 years. So again, she spoke to the CMO, and they said they're going to address her concerns so she can get the best care as possible. She ended up finally getting some proper pain management. However, she's not doing too well as far as COVID and pneumonia. She's coughing up blood. Update number 3, pulmonologist joins the care team. The CMO communicates to her that there's going to be some diversity training. They're trying to get an apology from the said doctor. Update 4, her oxygen saturations are down a little bit, but her blood pressure is stable. She does feel a little short of breath. She's likely to go home today. Update 5, she's home in her own bed about 12 hours later. Update 6, she's back at another facility, temperature 103, blood pressure plummets, 80/60, heart rate 132. She says everyone has to agree they discharged me way too soon. They're treating her for bacterial pneumonia as well as COVID pneumonia. She's getting pretty good care at this other place. Update 7, she's on BiPAP, ICU, and that's the end of the story. We don't hear anything else. And I'll just pause this video because you guys can't hear it. And she dies shortly after 2020. So this video essentially, it would provide a little more context, but this video kind of sums up a lot of the things that I was talking about before. It has potential racial bias in place, potential gender bias. It has potential stereotypical or stereotype placement. It has distrust. It has perceptions, all kind of in this anecdotal story. But what was kind of telling and interesting was that a press release, of course, that you got this social outpouring and pressure. So they released a press release in December 24th addressing the issue of racial equity in their facilities. This is by Dennis Murphy, the CEO of Indiana University Health. So I won't go through everything there, but a couple of things that stood out to a lot of people on social media, and I'll just go through a couple of these quotes. And the perspective of a nursing team trying to manage a set of critically ill patients in need of care who may have been intimidated by a knowledgeable patient who was using social media to voice her concerns and critique the care that they were delivering. Quote, I do not believe that we failed the technical aspects of the delivery of Dr. Moore's care. I am concerned, however, that we may not have shown the level of compassion and respect we strive for in understanding what matters most to patients. I am worried that our care did not have the time due to the burden of this pandemic and to hear and understand patient concerns and questions. So this essentially lit up a firestorm. And if you are thinking about, what's essentially wrong with this, the statement on intimidation needs to be understood in a broader historical context of people, particularly Black people, inciting fear in individuals just by being them. Stereotypes of kind of being animalistic kind of thing. So you need to understand it in that context. But you also need to understand it in that the intimidation is followed by like being a knowledgeable patient. So in the event that she wasn't a knowledgeable patient advocating for herself, would they have been intimidated? So it kind of needs to be appreciated where you have a lot of these characters throughout history, kind of Sambo-like characters, very jovial and unintelligent. And so just appreciate that statement. That's why a lot of people were upset about that. Not only that, but it perpetuates a stereotype of an angry Black woman in her advocacy for herself. And it, in my eyes, kind of makes excuses for behavior to where the response is almost as bad as the cause, kind of, where you just don't say how you're going to get better, apologize for what happened, but you set these kind of time constraints and excuses in place. So Dr. Susan Moore now lives as a hashtag on social media. So we kind of spoke about the healthcare disparities as an effect of bias, health equity, quality of life, justice, socioeconomics, essentially life and death, and in addition to our rampant suicide problem. Those are all other effects, but it would take many grand rounds to cover all of that. So moving forward, what can we do about this? We have this problem, what can we do? We need to address this implicit bias, first starting with the individual, and awareness. I can't say it enough, is the first step to combating this problem. We need to examine our personal beliefs, our values, our attitudes, our perceptions, and we can recognize what particular specific type of biases we have by completing the implicit association test, which I'll get to in a couple seconds. We need to understand the nature of bias, that there's pretty much nothing we can do to get away from it. It's a part of human cognition. So you need not to be kind of embarrassed by it, but understand how you can improve upon it. And discussions never hurt. Having open and honest discussions and the idea of allyship is very important. And one of the things about being an ally is not a label per se, it's more of a verb. So you're trying to create a culture of value and support and acceptance. So it's essentially a lifelong process where you have empathy, you're developing empathy towards the problems and challenges of marginalized groups. As far as on an institutional level, in addition to research, of course, we need ongoing continuous research to better evaluate the problem and see where we're improving, where we're not improving. But we need to develop concrete and objective indicators and outcomes in terms of hiring, evaluation, promotion, that helps reduce the stereotypes, because that's the level we're dealing with institutions. People getting promoted, people getting hired, those kind of biases. And again, on an institutional level, we can facilitate discussions and training to promote this bias literacy. And one of the things that you can do are these father-son activities. I know a lot of people may have come across this, but this is essentially a scenario where you have a father and son involved in a car wreck. The father dies on impact. The son's taken to the ER. He's going to get evaluated by a trauma surgeon. The surgeon comes down. The surgeon says, "Oh no, that's my son." Question is, how do you explain that? The father just died, right? How is that her son? And so in this scenario, about 40% of the people tend to make broad excuses on, was this patient adopted? Was the father actually a priest of some sort? As opposed to realizing that the surgeon is his mom. So that kind of discussion is always helpful. There's other things, the circle of trust, tag game, you can look those up. So I've been talking about this implicit association test, and it essentially is a way to measure implicit bias. And again, it's one of these reaction time measurement studies, and it's the gold standard right now for measuring implicit bias. There's been a past use of self-reporting, but it's essentially unreliable. They've looked at physiological changes, increases in heart rate, perspiration, blood pressure, brain activity. Those don't work. It's not admissible. It's like a polygraph. It's not admissible in court, so it's not going to be admissible here. And what the implicit association test essentially does is measures these associations between concepts and evaluations or stereotypes. So, for example, you have these words and they essentially want you to sort these words based on what you think they're associated with keyboard clicks, and you either go to the left or the right of the screen. So the idea is that you have concepts that are closely associated. The concepts that are closely associated are easier to mentally process, as opposed to the unfamiliar associations that take a little longer to process. And one of the places that has I definitely want you guys to check this out, is Project Implicit out of Harvard University. They have a myriad, as you can see, of implicit association tests that you can take and actually get results on. This is a nonprofit organization that was founded in '98 by a few individuals there, one at University of Washington, Harvard, and University of Virginia. And essentially, they just want to educate the public on hidden biases and have a virtual way to collect data on the internet. So it's a wonderful, wonderful site. And not only that, but Liz Redford so all the data is public, but it's not categorized or anything. So Liz Redford has this dashboard in which she creates figures out of their data. And I just put a couple here so we can see out of almost 8,000 individuals, about 0.5% of the sample that actually took the test from 2007 to 2016 had an average IAT score of 0.311. And that indicates a moderate implicit preference of white over Black people. You see how that graph is just shifted to the right ever so slightly. And another one on gender in science, about 8,000 individuals, again, 2% of the individuals that have taken it over 2007 to 2015. The average score was 0.342, again, indicating a moderately strong association with men in science as opposed to women in science. So, as we get close to our time, I did not forget about pathology, right? So even during this research, before this research, I always thought, how would bias present in pathology? A lot of the research and everything is very clinically oriented about treatment, people being in the clinic, so on and so forth. So I asked myself a few questions, like, for example, when we open up an EPIC chart and we see the little picture there, we see a foreign sounding name on the EPIC chart. Would that influence the interpretations of slides at all? Would an HPV or HIV status lead us to frequently increase the grade of dysplasia on an anal pap? Would there be any relationship between surgeon gender and pathologist gender and any kind of discordant frozen section diagnosis after we do the workup and find the actual diagnosis. Is there anything there? Pathology is a little more methodical and criteria based, so it kind of lends me to believe maybe not as much. However, with implicit bias being as pervasive as it is in society and medicine, I'm sure there's some. It's just a matter of doing the research and finding where it actually presents itself. Please check out the UCSF Office of Diversity and Research list of resources. It's great. You have things from introduction into implicit bias to the strategies to combat it, and everything in between. Great list. And on that note, I'll leave with this quote: "You cannot solve a problem with the same consciousness that created it. You must stand on a higher ground." Thank you, guys.
That was great, Antoine. Thank you.
Antoine, this is John Crossan. Thanks very much for that discussion. Your presentation, along with others, when I hear them, always remind me of the fact that when I was in medical school just a few years ago, this was in another city, but the racial and gender bias was just unbelievable. I could fill up a whole morning with stories about the bias that existed then. So that's a comment. The question I would like to ask, and you did allude to this a little bit, and can you expand a bit on social economic implicit bias that exists, particularly in medicine, because I'm sure it exists everywhere. But
I didn't go into great detail on socioeconomic bias, but at least as it refers to medicine. But the way I look at it is the kind of burden of, medical costs in a sense. And so if you have individuals getting inappropriate treatment or disparate treatment, these individuals are likely from a lower socioeconomic status, and I think it just affects those individuals differently in terms of what they're able to afford or not afford. But I'll have to look at that in a little more detail on how I know it affects it, but the details are something I will need to look at.
so it might get better if we actually had universal single payer healthcare, don't you think?
Yeah, I think so, for sure. I mean, it's an equalizer, but we'll see what can happen in the future.
Thank you, Antoine. I just second John's comment. This is an amazing presentation, very well needed. I want to take you up on, you didn't offer, but I will assume you offered to participate in a study in pathology. And I recognize you, I always did, as one of the leaders in this field. And we need people with your enthusiasm and knowledge. The issue, I like the slide about bias in pathology. Would you want to talk more about that and maybe develop a study, and again, to galvanize yourself as a leader? Because the examples you mentioned are very clever. I must say, in my own practice, HIV status does not influence my diagnosis of dysplasia. However, obviously, I want to check if the patient is immunocompromised, like transplant patient, because that is relevant. So, and I personally, you and I talked about this before, but I struggle with what we call pathologic associations. That is evidence-based in medicine. When I review a case of atypical endometrial hyperplasia, I want to check the patient's BMI. So BMI is associated with hyperestremic state. Low immunocompromised is associated with invasive squamous cell carcinoma. So these are things that I don't know what to call them. I'm calling them pathologic associations, but they are built-in bias, but it is different from the bias you and I are talking about now. This is kind of evidence-based bias. So it would be very nice to tease out these things. The three examples on your slides are perfect because they are not evidence-based. HIV has nothing to do with dysplasia. I forgot the two other examples, but the two other examples were also very clever because they are not evidence-based. Maybe we want to, yeah, the frozen section thing, maybe we want to talk, if you have time, we want to talk more about that and how we can design a study, because that would be very powerful. The data is there in CULPAB, and the discrepancy, the IOC versus final discrepancy you mentioned, that is measurable. That is a measurable thing. Does it matter if there's gender discrepancy between the operator and the pathologist? Stuff like that. Maybe we can talk more about it offline.
Yeah, definitely. Set something up for sure.
This is Dr. Dayton. I would love to agree with Mahmoud. First of all, that was an outstanding presentation. And second of all, that we're obliged as pathologists and as pathology educators to help our trainees and help medical students understand that there's certain things that you absolutely have to think about. You know, when a postmenopausal African-American female presents with vaginal spotting, you absolutely have to think of the possibility of adenoid cystic carcinoma, which is virtually only seen in postmenopausal African-American females. I mean, it's rare, but that's the only population you see it in. When you know, if I'm asked to look at a blood smear because a 40-year-old African-American male is presenting with back pain and anemia, I automatically am making sure that I look for the subtle changes of hemoglobin SC disease, which can present with a sickle crisis as late as, you know, someone in their 80s. The first sickle crisis can be very late in life, or it can be very early in life. And so, you know, how do I be, in a non-biased way, train medical students that, you know, 45-year-old African-American male presents with back pain and anemia, you have to include things like hemoglobin SC, first, you know, presentation with a sickle crisis, and you absolutely have to include plasma cell myeloma in your differential diagnosis, and you can't ignore it and you can't blow it off. How do I, you know what I'm saying?
Yeah, that's interesting.
Because plasma cell myeloma is so much more common in African-American men than in Caucasian men. You absolutely always have to consider it in your differential diagnosis. What's the right way to do it?
Yeah, but you see how we easily slide between one domain and the other. So if we accepted, because they are both types of bias, but the difference is that one bias is what I call evidence-based or scientific fact, the examples you mentioned, but there's another bias that has nothing to do with science. And yes, we need to develop an inventory of, I don't know how to develop a study like that, but this is really lacking in pathology. Pathology and radiology, those interpretive diagnostic fields, we are trained, and we train people to correlate data or to use all data they can get hold of. Every piece of information is available for me, but how can I separate evidence-based from just other biases that are cultural? Thank you, Antoine. This is a very good discussion. I really appreciate it.
Yeah, thank you.
Yeah, Antoine, you'll figure it out. You'll figure out how to do it. Thank you. Thank you. And
One day.
Tell me, okay, please? Thank you so much.
Oh, yeah. I'll keep you posted.
Okay, well, it was just this morning I got a message from Dr. Firkt that said, make sure you let all the questions be asked. So with that, you have gone way over, Antoine. Excellent job, though. Very good presentation. We will see you all next Tuesday. And everybody be well. Thank you.
Sounds good. Thank you, Amy.